Today, the topic of our lecture is Neuroimaging Part 2. So, for this lecture, you have to refer to the Part 1 of my lecture on neuroimaging. So, without further ado, let's start. Our first topic is movement disorders. Now, movement disorders are a cluster of neurodegenerative diseases which are progressive, and they usually happen with time, usually occur in old age, and they all result in one particular symptom that they affect the movement of the patient. Now, that movement is usually gross. It is not fine, it is usually gross. But movement disorders can result in fine motor disorders too. So, movement disorders, a cluster of neurodegenerative diseases which are progressive and usually are presented with age. So, whenever we are dealing with a patient who is presenting with any kind of neurodegenerative disease, it could be ataxia, it could be aphasia, it could be Huntington's chorea, it could be motor neuron disease. Now, these diseases can be both hereditary or it can be autosomal. Now, Huntington's chorea is an example of a disease which is hereditary, and it's a disease which also exhibits the sign of anticipation in its genetic hereditation. But other diseases are autosomal. So, whenever dealing with these diseases, the choice of modality is extremely important because the spectrum of movement disorders is a huge one. So, in order to diagnose them properly, in order to even have suspicion of a particular disease, the choice of modality is of utmost importance. So, the modalities that we usually use for these kind of disorders, the first one is the MRI or the magnetic resonance imaging. Now, this is the gold standard for any kind of neurodegenerative disease. Either it is central or it is peripheral, it doesn't matter. MRI gives us the best possible detail and information regarding movement disorders. Also, it is superior to CT scan because it has more options for both phasing and windows. Now, what are phases and windowing? You can look up for my lecture on the introduction of radiology, where I have explained all of this. Next modality that we use is the CT scan. Now, if for some reason MRI scan cannot detect a particular disease, but the symptomology is still there, then CT scan is used because sometimes some things are not picked up on MRI, they're missed. Then we used CT scan. CT scan can be both contrast enhanced, can be unenhanced, but whatever the reason, the first choice in movement disorders is always MRI. Then we move on to the CT scan. Our next one is the functional MRI. Now, functional MRI is a very special kind of MRI. Now, what happens is that during the process of MRI, there is a live feed of the patient's brain that the doctor can view on a monitor. Now, whenever patient produces a movement like a hand movement or a knee movement, the area associated with it starts to light up. In simple terms, that the neurons of that particular area that is associated with that particular movement start to activate, start to fire up, start to transmit their impulses. So this kind of observation of patient's movement under the MRI is what we called functional MRI. So whenever a patient with movement disorders, that that patient is not producing some kind of movement, or something is inhibiting that movement, that center will also show inhibition. That center will not show that kind of either involvement, or that center will totally be uninvolved in during the production of movement, even if the patient tries to move it. So functional MRI is a highly advanced form where we observe the live feed of the patient's brain whenever he's producing a particular movement, or at least he's trying to. Next is the MRI brain spectroscopy. Now, this is of very little interest in neuroimaging, but it is still used. Now, what happens is that during the MRI, again, a live feed of patient's brain is projected on a monitor, and doctor observes that particular image and all the slices along with it, with all the particular phases and the windows. But neurons, whenever they transmit an impulse, they produce certain kind of signals, and these signals are picked up on the spectroscopes. So if the functional MRI does not produce the desired result, or is not or it is producing a contradictory result, or you have some kind of suspicion that the functional MRI is insufficient, then spectroscopy along with the functional MRI is introduced in order to judge that if the neurons are functioning properly or not. Because as you might recall, in movement disorders, it is the neurons that are effective, that are slowly degenerated along the passage of time. Our next modality is the FGD PET scanning. FGD is the fluorodeoxyglucose PET scanning. Now, PET scanning is a highly advanced and highly specialized scanning. It is only reserved for if we want to confirm a diagnosis, or if there's some kind of a contradictory reports among the both the physical exam and the clinical correlation, or we want to test the patient for research purposes. Then we introduce labeled glucose inside the patient. Now, that labeled glucose is the deoxyglucose, and when that glucose is metabolized, gamma camera is used to take multiple images of the patient. Now, glucose is metabolized in the whole body. Now, if there is some problem inside the brain where the metabolism of the brain is not happening, PET scan or this FGD PET scan will pick up that particular area because the glucose is not being metabolized. Now, this can be due to a number of reasons, but one of the most common reason is a neurodegenerative disease. Next modality is a SPECT scan. SPECT stands for single photon emission computed tomography. Again, a highly specialized modality only used in certain conditions. Mostly it is used for research purposes. It has very little diagnostic value. We usually use MRI, CT scan, functional MRI. SPECT scan, even though it is used, diagnostic value is very little. Mostly either for research, or if we want to judge if our treatment is going as planned, or if the patient is showing any kind of symptoms other than the neurodegenerative ones. Next modality is the cisternography. Now, cisternography is used only in those conditions when there's some kind of a problem with the flow of the CSF of the or the cerebrospinal fluid, because the fluid inside the brain flows in a particular fashion from the lateral ventriculars to the third, fourth, then the spinal cord. It has a specific route, and all the ventricles both pull the CSF and help in its flow. Cisternography is a technique where we study the flow of the CSF. So, if there's any kind of degenerative disease, or there's some kind of mass because of it, or there's any problem that is hindering the flow of the CSF, we use cisternography. And this cisternography will give definitive answer that if any kind of hindrance or blockage or obstruction to the CSF is happening or not. Last but not the least is a flow sensitive MR sequence. Now, you must notice the word sequence, because this is not a technique or a separate modality of MRI. It is a particular window or a sequence of an MRI which can be done along with the normal MRI. In this MRI, what we do is that we study the flow of the fluid inside the patient, specifically the brain. Now, usually inside the brain, only two fluids are circulated: blood and CSF. But if there is some kind of edema, if there is some kind of restricted interstitial fluid, then we reserve our study to flow sensitive MRI sequences, because cisternography gives us information on CSF, but and the Doppler might give us information on the flow of the blood, but the flow sensitive MR sequences will give us the information on the other fluids, for example the interstitial fluid or the accumulation of one. Now let's start with some examples of movement disorders. Now this is a very common example of a movement disorder which is called normal pressure hydrocephalus. Hydrocephalus means that the patient is having more CSF than the required amount, but the patient is showing no signs, there is no symptomology. So such condition where the patient has more CSF but there is no symptomology, there are no signs, there are no symptoms, such condition is termed as NPH or normal pressure hydrocephalus. Now, this NPH condition can only be diagnosed on an MRI. This is a cross section of an axial T2 weighted MRI, and you can easily appreciate here that the lateral ventricles here are extremely dilated, and they are dilated because of the hydrocephalus, because of the excess amount of the CSF that is being circulated. So for NPH, MRI is the only diagnostic and the confirmatory modality that is being used. Our next topic here is focal neurological dysfunction. Now, movement disorders were again neurodegenerative, but they were of cross kind. Either they were central or they were peripheral, but they were cross. The whole of the nerve were involved, or the whole of the ganglia were involved. In focal neurological dysfunctions, what happens is that only a single point, a foci, or a single area of the nervous system inside the brain is affected. Now, the usual diseases which we might encounter in focal neurological dysfunction are the diseases such as aphasia, it can be other diseases such as ataxia, but one of the most common focal neurological dysfunction is a white matter disease known as an MS or multiple sclerosis. Because in multiple sclerosis, what happens is that white matter's arrangement is both hindered, uh, it is both in excess, and because of this patient slowly starts to suffer and slowly starts to have its particular symptomology, and it is a focal neurological dysfunction. So going further, a common example of focal neurological dysfunction is that along with MS, there are other focal neurological dysfunctions such as tumors, such as an abscess or a cyst. This is an example of a patient with a contrast enhancing primary brain tumor. Now, this brain tumor is, as you can see, is near the frontal cortex. Now, the frontal cortex and the prefrontal cortex are the one which are responsible for our cognitive behavior, and because of this mass is producing what is called mass effect or a space occupying lesion, because the presence of this mass is putting pressure on these cortex, the frontal cortex here, and because of this particular focal area is having neurological, because of this the patient is having neurological problems. Our next example is that not a single mass or a cyst or a tumor can produce focal symptoms. Sometimes there are multiple invasions or infiltrations inside the brains which can produce focal dysfunctions. Now, these focal dysfunctions are multiple, they're not singular, and one of the most commonest example is when a particular cancer or tumor metastasizes to the brain. This is an axial contrast enhanced MRI of a patient with a grade 4 breast cancer. Now, in this grade 4 breast cancer, the patient has metastasized breast cancer inside her brain. And as you can see, because of the metastasis, there are a lot of infiltrations and invasions inside the brain. And because of this, the patient is suffering from focal neurological dysfunction. So, stage 4 breast cancer with metastatic. Next, we have a corneal thin section pre-contrast T1 weighted MRI section of a patient with a cyst. Now, this cyst is near the pituitary gland. Now, one of the common focal areas that we usually encounter is related to either pituitary gland or due to the hippocampus. Now, this cyst here in this area is putting pressure on the pituitary gland here, and because of this pressure, the pituitary gland is exhibiting the symptoms of hypopituitarism. And because of hyperpituitarism, this is a focal neurological dysfunction. Now, as I said, that there are a lot of focal neurological dysfunction, but one of the most common, and I might add the most popular of focal neurological dysfunctions is multiple sclerosis, or simply called an MS. In MS, what happens is that white matter and gray matter inside the brain, their arrangement is totally disrupted, and because of this, patient slowly starts to have nausea, starts to have ataxia, chorea, tremors, a lot of problems. And this is all related to the white matter inside the patient. But all white matter anomalies are not MS. And this is a very good example of such case. Now this patient has white matter lesions which are very typical of MS. They are along the periventricular area, that they are along the lateral ventricle, but and they are hyper intense, but they are not MS. They are not multiple sclerosis. So what makes multiple sclerosis? In this image, we will study multiple sclerosis. This is a very common example of a multiple sclerosis patient's image, which is both contrast enhanced and T1 weighted. As you can see, again, there's a white matter lesion. It is paraventricular, that is, it is along the lateral ventricle, but the easy thing that you can easily appreciate here is that this lesion has inflammation around it. You can easily appreciate that these lesions have inflammation, and because of this inflammation, you can easily suspect that this patient has multiple sclerosis. Instead of having hyperintense paraventricular lesions, this information is very indicative that this patient has multiple sclerosis. Another point that differentiates multiple sclerosis from other white matter lesions is that this is an iso-intense lesion. As you might recall, the previous lesions were hyperintense. This lesion is iso-intense. It is not hyper. It is not as much white as those were. So it has almost the same consistency as the other white matter in the brain. So a multiple sclerosis white matter has two characteristics that differentiates it with other one. One, it will have inflammation. Other, it will be iso-intense, not hyper-intense. Okay. Our next topic is neuroendocrine dysfunction. Now, neuroendocrine dysfunction can easily be described as any problem with the pituitary gland. Endocrine system is a system in our body which produces hormones through ductless glands. An example would be adrenal gland, it would be pancreas, but there's one gland which is called the master gland. That this gland controls all the other endocrine glands inside our body, and that is the pituitary gland. And pituitary gland lies above the ethmoid bone inside the tunica sella. This is the pituitary gland, and this is the basal ganglia. This is the thalamus, and this is the basal ganglia. Now, and pituitary gland has two lobes, the anterior lobe and the posterior lobe. Usually, whenever we're talking about neuroendocrine dysfunction, we are usually talking about the anterior lobe because anterior lobe produces the hormone. The posterior lobe only stores the hormones. It is actually the hypothalamus that produces those hormones, the ADH and the oxytocin, but the anterior lobe is the one that produces the hormone. So whenever we talk about neuroendocrine dysfunction of pituitary gland, we're actually talking about the anterior lobe of the pituitary gland. Now, whenever there is dysfunction with the pituitary gland, it usually comes up in two states. Either it is hypopituitarism or it is hyperthyroidism because of the increased production of TSH, that is the thyroid stimulating hormone, the hormone that stimulates the thyroid gland to produce thyroxine. Now, this is a microadenoma of pituitary gland which is hypoenhancing. Now, in my previous lecture, I stated that all pituitary edemas are categorized either as macro or microadenomas. Less than 1 centimeter, they are microadenomas. More than 1 centimeter, they are macroadenomas. Another characteristic of a pituitary adenoma is that it is hypoenhancing. Hypoenhancing means that the lesion itself is of hypointense, but the tissue surrounding it has the particular quality of being enhanced. So all pituitary adenomas are hypointense and they are usually microadenomas. Macroadenomas do exist, but microadenomas are more common. And even among the microadenomas, about 20% of all of them are non-functioning. They do not produce any particular kind of symptomology. So this is a very good example of a pituitary adenoma which is causing the neuroendocrine dysfunction inside the bone. Now this particular pituitary adenoma is most likely a prolactinoma because it is the most common pituitary adenoma. Pituitary adenoma producing growth hormone, they do exist, but pituitary adenomas which produce either TSH or LH luteinizing hormone or FSH, that's the follicle stimulating hormone, those are very rare. Prolactinoma is the one that is the most common, and here this particular adenoma is a prolactinoma, that it is producing prolactin. Next is a midline sagittal contrast enhanced T1 weighted MRI of a patient with a very particular condition called an empty sella syndrome. Now, what happens is that pituitary gland, because of the invasion of CSF inside its sella, inside the area where it resides, it is totally swept with CSF, and because of this, the area is totally empty. As you can easily appreciate here is that this is the area where the pituitary gland lies. This is the remnant of the pituitary gland, and this is the CSF, which is occupying the area which should be occupied by the pituitary gland. And you can also appreciate that the detail around this area is very murky. It is very good around here, but around here it is very murky. It is murky because of the invasion of CSF, and this is what is called an empty sella syndrome, and this results in hypopituitarism. Our next topic is epilepsy and seizures. Now, epilepsy and seizures are usually termed alongside each other. They are kind of synonyms of each other. Though epilepsy is a particular disease, seizures is the manifestation of that disease. But in normal speak, in books, both terms are used interchangeably. Now, seizure is a condition where a single focal point inside the brain forces the whole of the body to jerky movements, to a lot of tonic movements, to a lot of clonic movements. Sometimes they're even incontinence. So a single firing foci inside the brain will cause the whole of the body to lose consciousness and will undergo massive jerks and seizing. This is what is called an epilepsy. Epilepsy usually has two types. Either it is grand mal, the usual kind that we see, the tonic clonic one, where the patient loses consciousness and has jerky movements, or it can be petit mal, where the patient loses his consciousness, but the jerky movement is not there. It is less. One of the common kind type of petit mal seizures are the absence seizures, where there is a focus inside the brain. The patient is only experiencing the absence of consciousness for a little while. Now, for epilepsy and seizures, imaging is usually not required unless we want to rule out any kind of neurological problem that might cause it. One of the most common causes of seizures of epilepsy are either tumors or some kind of problem or lesion in the hippocampal area. These are the areas where any lesion, any problem, any damage will lead to seizures. This is a very good example of a patient with hippocampal atrophy on the left side and normal hippocampus on the right side. Like I said, that the focal area from which the epilepsy arises usually lies around the temporal lobe or around the hippocampal areas. This patient is having hippocampal atrophy, and because of this hippocampal atrophy, the patient is suffering from seizures. And you can easily diagnose, easily appreciate the difference between the both hippocampal areas. This one is normal, it has discrete boundaries, it has both iso and hyperintense margins, but this one here is again irregular, it is disarranged, and it does not have regular discrete margins. Our next one is a corneal flare sequence. Now, flare is again a sequence of MRI. It is not a modality, a separate modality. It is a sequence that we perform during the MRI. And during this, we can easily find out that if this intense hyperintensity in this patient is causing seizure or not. Because if on functional MRI, on FLAIR sequence, if this hyperintensity here, if this one is showing signs of hyperactivity, that means that this is the focal point of that patient's epilepsy and the continuous seizures. So you can easily appreciate that this hyperintensity is only on the left side. It is not paired, it is different from the other, and this is the one which is causing seizures in this particular patient. Now, imaging for epilepsy should never be done like a separate entity. It is always done with both the clinical correlation, with the physical exam, with the lab tests, and they're all correlated, and then either the suspicion or the final confirmation and the diagnosis of that person is made. So for the epilepsy, imaging is one of the multidisciplinary approach that is used to diagnose it. In itself, it is not enough to diagnose both an epilepsy or seizures. Our next topic is dementia. Now, dementia is defined as the loss of cognitive ability or abilities well beyond one's normal age. For example, a patient in his 30s starts to exhibit signs and symptoms which usually appear during a patient's 60s or 70s. So, dementia again is a multidisciplinary problem. It should only be approached through a multidisciplinary point of view. Imaging alone cannot diagnose dementia. It can provide you with suspicion. It might confirm the suspicion of dementia, but alone imaging cannot provide any definitive proof that dementia exists. And one of the most common conditions that are usually seen, symptoms that are usually witnessed among the patients of dementia is memory loss. And among memory loss, a particular disease is of particular interest that is called the Alzheimer's disease. The patients with Alzheimer's disease starts to exhibit symptoms of memory loss, both long, mid-term, short-term. Sometimes when it even advances to the later stages, long-term memory is also affected. So dementia again is a very important topic because of the proliferation of Alzheimer's disease in both the developed countries and the developing countries. A lot of research is being done on Alzheimer's disease. A lot of awareness is now available. A lot of help and support is available for the Alzheimer's disease because of its prevalence in the world. Now, for dementia, one of its hallmark is what we call UBOs, or the unidentified bright objects. Now, whenever they appear on any scan, now this is an axial T2 weighted FLAIR sequence of a patient, but this patient is only showing bright objects which are random. There is no inflammation around them. They're not posing any kind of mass effect. They're not occupying. They're not pressurizing the parenchyma. They're just there. So these kind of unidentified bright objects are the hallmark of dementia. And dementia, along with Alzheimer's disease, can occur both through these bright objects, but there are also other kind of dementia like angiopathic dementia or multiple dementia. So we will see them further down the slides. So these are the T2 weighted hyperintensities, which are usually termed as unidentified bright objects. And these are the hallmark or the pathognomic of dementia and Alzheimer's disease. Next one here is an axial T2 weighted MRI of a patient with a very particular problem, that this patient is experiencing microangiopathic white matter changes. Now, as we all know that in brain, the outside is usually the gray matter, the inside is usually the white matter. And in dementia and Alzheimer's disease, white matter, unidentified bright objects start to appear. Now, they can be both random, irregular, dispersed along the brain, or they can be clumped together with a vascular characteristic. And this is a very good image which particularly demonstrates it. As you can easily appreciate here that this white matter here is having microangiopathic changes, that it is having both edematous changes. We can say that these are edematous changes because of the loss of the um, discrete lining, because the change is both murky. So these white matter changes are due to vascularity, the change in vascularity of that particular patient. So in dementia, either random white spots appear, or the vascularity inside the white matter of the brain starts to undergo changes and starts to exhibit microedema and microangiopathic changes. And this is what is called microangiopathic dementia. And this is very different from the dementia which exhibits the unidentified bright objects. Our next topic here is, now this again here is a person with bright object in his frontal lobe, and because of the presence of this, now white matter should not be here, this white area should not be here, and because of this the subarachnoid spaces have expanded and have started to place pressure on the inside of the brain, and because of the inside of the brain is being pressured in, the ventricles are losing their space, they are being clumped in, and this patient is again suffering from dementia. So, dementia is due to disarrangement of white matter. It can be irregular, termed as UWO, it can be microangiopathic, or it can be like this, that they appear in place of gray matter and then they start to disarrange the gray matter of that particular patient. Now, this one here is the hippocampal atrophy of a patient that is suffering from dementia. Like I said, brain is covered with gray matter, and inside of it, it is composed of actually white matter. And that white matter is mostly basal ganglia. And hippocampus is usually is not usually is a part of the basal ganglia of a particular patient. It is actually a part of the internal capsule. So whenever hippocampal atrophy happens, it can result in both seizures, as we discussed earlier, or it can it can present as dementia, because hippocampus is the entity which is most commonly associated with the formation of memories. Like I said, the most popular and the commonest example of dementia is Alzheimer's disease. And in Alzheimer's disease, patient starts to lose track of time, starts to lose his or her memories. And here, because of hippocampal atrophy, because hippocampus is responsible for making short-term memories long-term, and for the recall one of the long-term memories, because of its atrophy, the patient is suffering from both dementia and memory loss. Our next example is last one, that there's a particular disease called Pick's disease, and Pick's disease is very similar to dementia because it has the same symptomology, same progression of symptoms, but on imaging the presentation is widely different. Now, instead of having bright objects or white matter dispersed throughout the brain, what happens is that the sulci on the both side of the patient are mismatched. As you can easily appreciate here, that the subarachnoid space and the space between the pia mater and the arachnoid mater, it is extremely widened, and it is not complementary. The other side is normal, the left side is widened, and this is pathognomic and very indicative of a Pick's disease. So, a patient with dementia, with symptomology of memory loss, of Alzheimer's disease, might not have actually have Alzheimer's or dementia. He or she might even have Pick's disease. But in order to confirm that, if you have suspicion, or it might even arise as an incentidoma that you are actually looking for signs and symptoms for Alzheimer's disease, where you actually find Pick's disease here. So this one is very important because again the symptomologies match. So in this lecture we studied first and foremost the movement disorders. What are movement disorders? What are they? What is a central one? What is a peripheral one? We learned that movement disorders are the one where neurodegenerative changes starts to happen, and they're progressive, that they do not stop at a particular point, they keep on going until the all of the neurological system is compromised. Then we moved on to the focal dysfunction, that not only it happens crossly, that all over the brain, mostly what happens that only a focal point or a particular point in the brain is affected. We learned about that. We learned what it is, which different diseases exhibit such kind of behavior, and how it can be diagnosed on imaging, what is role of imaging in both the gross and focal neurodegenerative diseases. Then we learned about both the epilepsy and the seizures. What is epilepsy? What are seizures? And how they happen. We learned that there's a particular method to them, that they mostly happen due to a problem with either the temporal lobe or the hippocampal area. And we also learned how to distinguish different presentations, and how imaging is only a part of the diagnosis of epilepsy. Then we learned about the Alzheimer's disease or the dementia. We learned what is dementia and why dementia is starting to become more common because of the Alzheimer's disease. We learned what Alzheimer's disease is. We learned how it affects our brain, what kind of an objects, what kind of presentation do we see on those images, and how to differentiate it with the Pick's disease. We learned all of this in this lecture. Thank you so much for watching sqadia.com.